I'm going to switch gears a little bit and talk more from a imaging and nuclear medicine perspective, talking about the really exciting advances that have been taking place over the last few years in the field of molecular imaging for prostate carcinoma. I don't have any disclosures relevant to this presentation. So what we'll talk about in this next few minutes is we'll talk about molecular imaging of prostate cancer as a general principle. We'll talk about the first generation of molecular therapies that we now have access to, and a little bit about the future directions and, importantly, some of the headwinds that we'll face as we look at implementing these for our patients. So, of course, the big buzz right now is around PSMA imaging, as we've seen in some of the previous presentations, prostate-specific membrane antigen. We've had a class of molecular imaging agents for prostate carcinoma. Choline-11 has been around for a number of years, really put forward by the Mayo Clinic. Now we had the amino acid tracers after that. Fluciclovine came along, but kind of percolating all along in the background was PSMA, and for various reasons we had the thought that these were going to be superior imaging agents for imaging of prostate cancer. It's a little bit of a misnomer, though, and it's important to think about this. As I sit and look at PET imaging studies and nuclear medicine imaging studies, it's always important to remember what you're actually looking at and not fall prey to just think that, PSMA, I'm going to look at prostate cancer. PSMA is a little bit of a mysterious protein. It was identified as a cell surface marker that exists certainly on the surface of prostate tissue and prostate cancer, but it's a membrane glycoprotein. It's encoded by the FOLH1 gene. And really nobody knows exactly what this protein does on the surface of the cells. It's expressed on prostate epithelium, but it's also expressed in renal proximal tubules, jejunal brush border cells, and on CNS ganglia. And it's thought to have a role in glutaminergic neurotransmission as well as folate absorption. So kind of this mysterious protein that's out there. We know that it exists on prostate, but we're not sure exactly what it does. There are multiple imaging agents that have been developed. I didn't put the trade names in here just to remain neutral, but just to recognize that there are always new agents in development. In my mind, at this point, I don't have a preference one over the other. They all fundamentally image the same receptor. There may be some differences depending on whether it's gallium-68, fluorine-18, having to do with the half-life and resolution of the particular radioisotope we're dealing with. But functionally, as I just put these all on one neuron, think about them as PSA imaging studies. Here's a couple of images from studies done, PSMA PET imaging studies. We can see an imaging study here on the left-hand side that is normal, so kind of normal biodistribution. A little bit different than what we've been doing for many years with FDG PET, and those of you who have done FDG PET imaging in your patients, you kind of get used to looking at those scans. We don't see any brain imaging because the agent doesn't really cross the blood-brain barrier, and the brain has no intrinsic affinity for the PSMA. But we do see a lot of intense renal activity. We see hepatic activity. And obvious uptake in the salivary glands, and I'll walk through this in a little bit. Here's a patient in the middle that has kind of our classic retroperitoneal nodal spread of disease, so somebody with an elevated PSA, and we see increased uptake in those retroperitoneal lymph nodes as well as that biodistribution. And then a patient here on the right-hand side that obviously has very advanced disease, widespread osseous metastatic disease, showing uptake of the PSMA imaging agent. Interestingly, you see this phenomenon that we sometimes see with other types of PET studies, where the more the radiotracer is going into the disease, it almost sucks it all up and has less biodistribution. You can see the tissue to background ratio on that right-hand side is much lower because all of the radiotracer is going into tumor, and the hepatic activity, for example, is much less intense because you have so much redirection of that radiopharmaceutical into the sites of disease. So I thought I'd walk through just a little bit of the process as we look at these scans. This is a patient we imaged at Baylor College of Medicine. We now do have access. It took us a little while to get this up and running. There are supply chain issues. You have to get it on the hospital formulary. You have to work out the billing issues. So it took us a little bit of time to work our way through. But this was a 61-year-old patient, 61-year-old man who presented with urinary obstruction and prostate hypertrophy. And when he went for a TURP procedure, was found to have high-grade prostate carcinoma in his gland. And so this wouldn't be the typical indication. Normally, we're doing these patients after they've had some sort of therapy, intervention, surgery, and now their PSMA is rising. That's kind of the classic indication for molecular imaging in a patient with prostate cancer. But here we moved it up in somebody that we had a pretty strong inkling that they had high-grade prostate cancer, pretty high reasonable pre-test likelihood of spread. So we opted to do the PSMA PET image scanning beforehand to see how far the disease is spread and get them onto appropriate management. So this was done with the PSMA 11 radiopharmaceutical, which is what we have access to at Baylor at this time. So here's a view. So I have the maximum intensity projection image over on the left-hand side, and then some select images from the axial images of the CT and the PET CT. And we can see there are several foci of fairly intense activity in the prostate gland itself. It's always important to consider the pretest likelihood in the clinical scenario, because if you just pulled somebody off the street with, an older man with prostate hypertrophy and you did this scan and the prostate gland looked like this, not really sure what it means. Is this BPH? Is it prostate cancer? The positive predictive value of this sort of finding isn't high enough to really know what to make of that finding in the absence of clinical information. But of course, in this case, we know that this patient has prostate carcinoma, so reasonable to assume that this activity in the prostate gland represents his known primary prostate carcinoma. A little bit higher up, if you look at the axial images, we can see focal activity here along the left pelvic sidewall, along the external iliac region. Presents one of the pitfalls that we sometimes see with these imaging studies. Pretty easy to look at this axial image and say, oh, there's a little bit of soft tissue there on the CT scan and very intense activity. But of course, as we correlate that with the MIP image, and if we were to follow that up and down, we see that just represent urinary excretion of the radiopharmaceutical. So we sometimes can mistake these. It's easy when you see a nice linear area of activity, but sometimes because of the way the ureter peristalsis, you'll have a single focal area of activity, and you have to go back and forth between the axial CT images and the PET images to really reassure yourself that this does not represent disease. So in this case, this just represents urinary excretion of that PSMA 11 compound. In this case, we see something that we didn't really see on some of the earlier images that we saw, and that is this curvilinear intense activity in the upper abdomen, which corresponds to the second, third, and fourth portions of the duodenum. And you'll recall that I indicated that this agent is also expressed on jejunal brush border and other areas of the bowel. So again, we don't really know what this means and why we see this finding in some patients but not other patients, but it probably has something to do with their innate folate metabolism, really a fascinating thing. And it always makes me wonder, like in the back of my mind as we look at these scans, I'm sure we're seeing something that is meaningful from a biochemical standpoint in these patients, but we just don't know what it means. But again, important to recognize that this, number one, doesn't represent prostate cancer. Number two, in certain settings, could potentially mask subtle findings. If you have nodes in the upper retroperitoneum adjacent to a very site of intense activity like this, it could potentially mask that nodal activity. So that just represents normal physiologic jejunal activity, again, thought to be related to folate metabolism. This is a really fascinating thing, and this actually, in the early days of PSMA imaging, did lead to some overcalling, and that is you sometimes see these very focal areas of activity up here along the retroperitoneal and upper supraclavicular regions. I had to increase the intensity a little bit to see it in this case. Sometimes it's a little bit more intense, but we can see this focus of activity right here along the paravertebral fossa. It's a little posterior to where you'd expect a supraclavicular node to be, but we do see definitely supraclavicular nodes in these patients. But this is now a known finding. It represents uptake in the neurogenic ganglia. So this is the stellate ganglion. You can also see this activity in the celiac ganglion in the upper retroperitoneum, where it can be a little bit more problematic. Certainly right in an area where you're expecting to look for nodal disease, you can see these sites of activity. So now that we know that these ganglia can take up PSMA, we know that not to fall prey for this when we're reading these studies. So again, something to do with that glutamatergic neurotransmitter expression. And then finally, in this case, something that we still don't really know what to do with, this patient had a thyroid nodule. So in the right lobe of the thyroid gland, we can see a small hypodense nodule in the thyroid gland that actually shows a little bit of PSMA activity. It's not prostate tissue. It's not a site where we would think that there would be metastatic prostate cancer, but focal activity there in the prostate gland. So what do we make of that? We're really not sure at this point. Probably deserves further workup. It's not prostate cancer. Shouldn't slow down the workup and appropriate therapy for this patient's prostate cancer, but something to keep in mind. So ultimately, with the result of the PSMA PET scan, they were confident, reassured that there was no evidence of distant metastatic disease, went to surgery, did have high-grade prostate cancer, Gleason 4+5, did have capsular invasion, but did not find any metastases in the periprostatic space or lower retroperitoneum pelvis. And then thyroid ultrasound in this case is pending to work up that thyroid nodule. So one of the pitfalls, just to talk about this, and we referenced this a little bit in the earlier session, PSMA is an amazing radiopharmaceutical and generally shows very strong localization for prostate cancer. Certainly, in my mind, it shows superiority over some of the earlier radiopharmaceuticals that we had. But there are cases of PSMA negative disease, and this can occur in a couple different scenarios, but one of the main ones is neuroendocrine dedifferentiation of prostate cancer. So as you move towards these higher grade prostate cancers and start to get neuroendocrine features, those tissues tend to lose their PSMA avidity. They no longer express that PSMA molecule on the cell surface. So this is from an article. I don't have a real-time case from Baylor, but an article with obviously large lymph nodes in the retroperitoneum with a PSMA scan essentially negative, that these nodes do not show activity. Not so much a mystery in a case like this where you have 3 centimeter lymph nodes. You're not going to miss those on CT, but you can imagine somebody with a 0.8 centimeter lymph node in the retroperitoneum with neuroendocrine differentiation could potentially be PSMA negative and lead to a false negative result. There seems to be a flip. We're pretty early in understanding of all this, and studies will need to be done to truly understand, but as the PSMA localization and avidity goes down, FDG activity tends to go up, so these neuroendocrine prostate cancers tend to be more FDG avid. So there may be a role for FDG imaging, which we've traditionally not done for prostate cancer, but in neuroendocrine differentiation, there may be a role for that. There certainly are cases of false positive, and the list is probably longer here for the types of things that show uptake of PSMA that are not related to prostate cancer. Any radiopharmaceutical can show nonspecific localization. Uptake of radiopharmaceutical is related to specific localization, whatever the receptor is. It's also related to nonspecific binding, and it's also related to flow and hyperemia. So any inflammatory condition that has increased flow can show some generalized background increase of radiopharmaceutical. So that is something to keep in mind. Abscesses, generalized inflammation, granulomatous inflammation, sarcoid, all these things can show kind of low-grade nonspecific localization of radiopharmaceutical. Other malignancies can also express PSMA. Renal cell carcinoma is a known one. There are cases of thyroid carcinoma, such as this case from the literature with a large mass in the upper chest along the paravertebral space, showing increased uptake of PSMA. Squamous cell carcinomas have shown uptake, small cell lung carcinomas. The list is going to go on and on. So this is the sort of thing that the more we do this imaging, the more we're going to come across these incidental second primary malignancies. With FDG imaging, we know that patients generally have about a 1 to 2% chance of having an unrelated malignancy that shows up on FDG imaging that's not why we're imaging. And we'll probably start to see similar things in the PSMA imaging crowd. Older men being imaged with prostate cancer have lung cancers, they may have occult pancreatic cancers, they may have other things going on that may show up on the PSMA imaging. And then the non-malignant conditions as well. Paget's disease of bone has been shown to have increased activity. Schwannomas and neurogenic tumors, because of that GABAergic localization, can also show activity. So beyond imaging, this all leads us into the concept of theranosis, which is an approach that we've had over the last few years where once we have a molecularly targeted compound that localizes to a particular tissue, when we can use that for a diagnostic imaging agent using a diagnostic isotope like gallium-68 or F-18, we can now conjugate that to a therapeutic isotope such as lutetium-177 and then use that to actually treat the malignancy. We've done this with neuroendocrine tumors and now, of course, with PSMA. The principle is very generic, so there's a lot of room for exploration. The commercially approved agent in the US right now is lutetium-177 PSMA compound. But there are a lot of a lot of therapeutic trials that are taking place in the phase 1 and phase 2 arena looking at other potential therapeutic compounds. So this was the trial that led to the approval of the current PSMA 617 in the US, labeled with lutetium-177. The VISION trial, published in the New England Journal of Medicine, I'm sure all of you are familiar with, but showed a substantial improvement in overall survival compared to standard therapy alone. So these are patients with at least one side of metastatic disease, progressed on conventional therapy, and then enrolled in the trial to receive either best standard of care therapy versus lutetium-177 PSMA 617. And you can see median cycles was 5 cycles, cumulative dose 37.5 gigabecquerels, but really a striking improvement in overall survival. This was progression-free survival. Overall survival also showed improvement, as well as time to first skeletal event. So this did lead to the FDA approval of the lutetium compound for treatment of metastatic prostate carcinoma. As I mentioned, a lot of room for exploration. This was a study down here at the bottom using terbium. There are studies looking at lead. There's a lot of interest right now in alpha therapies. So lutetium-177 is a beta emitter, which is a pretty reasonable therapeutic agent for cancers. But there's some thought that alpha therapies, like with radium-223 that we use for skeletal disease, if you can conjugate an alpha emitter to these PSMA compounds, may lead to even better outcomes. So what are the headwinds to broad adoption? This was a nice study that came out of Brigham and Women's and that group up in Boston, looking at their experience with clinical implementation of the lutetium-177 compound. And lessons learned. So what they really found, a couple of observations that they made, this really needs to be done in a multidisciplinary setting. And so as we've heard, I mean, even as I sit here this morning, there's a lot of debate and a lot of room. You know, we know this and we know this, but what about the 90% of patients that fall somewhere in between? You know, what is the best course forward? And this offers a potential therapy for these patients, but how does it rank vis-a-vis, you know, stereotactic radiation therapy for oligometastatic disease, surgical resection for oligometastatic disease? You know, clearly this would be on the more advanced patients, but there may be a role in earlier disease as well. So having those discussions at tumor boards is really critical to having a robust program. This is an area where I live in the day-to-day basis, and that is the supply chain. These tend to come through very narrow bottlenecks. You have one vendor that has an approved agent. The production of the radiopharmaceutical may only occur at a couple of different sites and has to be shipped worldwide or shipped nationally. And when you have a disruption to that supply chain, it could lead to some pretty significant downsides for patients. We saw this with radium a number of years ago. Some of you who had patients on radium therapy may have experienced it, where the generators in Scandinavia were contaminated. So they had to shut down the program worldwide. And we had to tell our patients in the midst of their radium therapy, you're not going to be able to get your dose for another 2 months. You know, here we're telling them every month you need to come in. It's very important that you come in. And then we tell them you need to wait 2 months for your next dose. We're similar things with the lutetium-177. When you have a program that's scaling and growing, it may be difficult for the vendor to supply the radiopharmaceutical on the scale and the schedule that you may need them to do. They found in this particular retrospective review, there was a 3-month delay in the delivery of drug in some cases, and 5% of patients were dying while awaiting treatment, just to be able to get them on the treatment, to be able to assure a consistent supply chain. And then maintaining a strict regimen for treatment. You know, you need to make sure that the patients are appropriately qualified. This is not something that you just offer to a patient off the street. Like I said, that multidisciplinary approach to make sure that you've considered surgery, considered radiation therapy, considered medical therapy to really identify who the best patients are for this. These are the distribution facilities across the nation as of a couple of weeks ago. You can see it's a little bit sporadic here and there. Those of us that live in major metropolitan centers have pretty ready access to this agent with multiple production facilities in the area, but you can see there's significant swaths of the US, including the entire state of Alaska, where there is not a facility for distribution of this agent. I just throw in this last topic just because it's something that I think about in terms of how we approach imaging and in particular nuclear medicine diagnostics and therapies. The map corresponds pretty well to the population density of the U.S., but when you start to look at the racial-based breakdown of the U.S., you can see on the left-hand side, here's the major areas of Hispanic population in the U.S., and you can see that goes through an area that is generally underserved as far as the availability of these agents. This is the population density of Black and African American population in the U.S., and you can see that also goes through an area of the South that is generally underrepresented with availability of these agents. So I think there's a certain issue that we need to be cognizant of anyway, that this agent, as it does become approved, has some accessibility and availability to the perhaps more vulnerable populations. I was just having a conversation with Dr. Godoy between the sessions here that, we have the privilege in Houston of working at Bentop Hospital with a large component of underserved and underinsured and immigrant populations. We really want to make a run at getting some of these agents available for those patients, even though in the county hospital system, finances and reimbursement and things like that are a consideration, but in some ways they're even more needy than some of our other patients. So we want to make sure that they have access as well. So just something to put in the back of our mind as moving forward with all this. So in summary, modern Theranostics really is built on a long history of what we've done in molecular imaging therapy, but it really is a renaissance, particularly in the area of prostate cancer with the advent of the PSMA agents. I think there will be a rapid advancement of these agents in the near future as we discover the best diagnostic agents, the best therapeutic agents, and the best patients in order to give these therapies in order to impact their overall survival. But care must be taken to ensure that the discipline is sustained, operational considerations, future practitioners, and then, of course, patient access. So thank you again for the opportunity to be here today, and I think we're going to answer questions at the end. Thank you.